Okay, let's continue with this review. Let's talk about oncological emergencies. Good morning, Michael. I'm gonna be aware that somebody's. What time is it? 8:38. Okay, oncologic emergencies. What are you gonna do with hypercalcemia? What signs and symptoms you're gonna see in people with hypercalcemia? Say again. It affects entire muscles, okay? It can be weak muscles. But at the same time, remember, hypercalcemia is critical because the main muscle is your heart, okay? We exchange ions and anions in the heart. So if we have hypercalcemia, your heart is your main concern. Forget about extremities and forget what happens, you can resolve that. But if it's something concerning with your heart, that patient is in high risk, you literally can explode that heart with so many calcium ions there. So telemetry, of course, there needs to be monitored for those arrhythmias, in fourth semester. Don't go and deal with this right now, but we can see a lot of BTACs and PVCs and hypercalcemia. And an increase in the T weight too. Again, don't worry about those right now. Worry in fourth semester because you're going to have those streaks in fourth semester. So, what about, let's see, vena cava syndrome. What are the signs or symptoms of vena cava syndrome? What happens when something is obstructed in your vena cava? Mm-hmm. Does somebody say something? Swelling, especially where? Neck, chest, hands. Okay, so respiratory failure can be a concern. And it's very red, very swelling. These patients are really very, very sick. What is lymphedema? Lymphedema. Remember, that's an obstruction of the lymphatic system, and that happens when postoperatory after mastectomies. We don't take care of this patient and we continue doing blood pressure and IVs in those arms, right? If the patient has bilateral mastectomy, you have to use the legs. And that's a policy for all the hospitals, okay? And patients get very upset if you try to get a blood pressure in the arm. Yes, Maria.
So, for the lymphedema, swelling of the lymph, right? Or is it obstruction?
It's an obstruction of the lymph nodes. Remember, the lymph nodes has been removed, so the ones that is left there, they don't have enough ways to move that fluid. So you see the arm that is swelling. You have to keep that arm elevated in the patients in the hospital or recommended at home, elevated all the time. Again, no IVs and everything. So be sure to know about lymphedema. And that you're going to see that a lot in your practice, a lot in all the units, lymphedema. What is the care of, how do you take care of the patient with total prostatectomy, removal of the prostate? How do you expect the patient to come to the unit? That patient is going to come to the med-surg.
They're going to come with a Murphy drip, probably.
Murphy drip.
With a Murphy drip, the triple lumen polycatheter.
Triple lumen polycatheter. Mm-hmm. That's right. Yeah, and what did I say about the irrigation? The bags are 1,000 milliliters each bag, okay? And you're going to be super busy because it's open line. So once that bag empty, you keep empty the Foley, put another bag, empty the Foley, put another bag, empty the Foley until what? until the urine is clear. Exactly. We try to stop that bleeding, those clots coming up. So cleaning the bladder and everything is the best treatment. Remember, after you remove that Foley catheter, especially it's huge, that's going to be very painful for that patient. You can see a little bit of blood after, which is normal, and it's going to be painful for the patient the first time they urinate. All right? What is the marker for prostate cancer, or one of the markers?
That's not prostate.
Prostate cancer. I can hear you.
Faces in urine function.
What is the genetic marker? Remember, breast cancer, which are the genetic markers for breast cancer? Prostate cancer? PSA, that's one of the markers. If it's elevated, that's a chance the patient is possible first for enlarged prostate, and second is risk for cancer, right? However, that's not the final diagnosis. In order to be sure there's cancer, what is the diagnostic test that we do for those patients? That's the initial. That's the initial. But what is the test? What diagnostic test is performed in order to know if it's cancer or not? Biopsy. That's the only one. Histology is going to show those cells. Okay, the irregular cells. Sometimes they are not defined. Remember the staging. And the histology also can show how big the tumor is and how if it's metastasis or not. All right? What is the medication to tamoxifen? It's for breast cancer. And what is the mechanism of the action? It's an estrogen blocker, exactly. These patients, I remember I said, usually take it for 5 years, okay? How do you protect yourself from this medication? Because it's a chemotherapy medication and you see it very frequently in med-surg. How do you protect yourself? You're going to give like the rest of the medications? Double gloves, okay? Double gloves. There you go. Put it in different cup. What is the name for pancytopenia? Pancytopenia. Pancytopenia. What that means? If you don't know the words for pancytopenia, thrombocytopenia, leukopenia, all those, you need to know those mean, okay, in order to understand the test. Pancytopenia. Remember, that's the word that means that all the three kinds of cells are low. Okay, that means low platelets, low red blood cells, low white blood cells. So that patient is very, very sick. And that's the patient that you're going to have on oncology units. Okay, you're going to be super busy in oncology trying to elevate those numbers. Okay.
What are the two again?
Red blood cells, white blood cells, and platelets. Okay. Remember, what is your care for neutropenia? What is the prevention that you're going to have for this patient? What are the neutropenia precautions? Mask, gloves, okay. Actually hand washing, okay. What kind of foods? No fresh foods, flowers, maybe the visitors, right? Be sure to know that neutropenia precautions. What means thrombocytopenia? And what are the precautions for this patient with thrombocytopenia? There you go. You got it.
What is this?
You can say it now. Okay, very good. So prevent some injuries, that's what we mean, right? Prevent some bleeding. There you go. Remember that what is the medication, especially if you're going to monitor after giving a chemotherapy drug that gives the congestive heart failure sign or symptoms? Which one it is? I talked very extensively last week about it. But I said look for these medications because you're going to have some congestive heart failure after. And that's where your care comes. Perfect. You got it. Say it loud so everybody can hear you.
The Doxorubicin?
Uh-huh. That group of medications really give very congestive heart failure, and usually you can see after 6 or 1 month. Can you hear me? No?
No, we can hear
You can say it loud.
Doxorubicin?
Doxorubicin. Very good. How do you increase the red blood cells in the patient? What is the medication that we use? Broccoli, right? Sorry, say it again. That's not broccoli. Increase red blood cells. Say it. Mm-hmm. The other name is EPO-18. EPOTIN. Okay. So review in a few words. Review what something else. What is your interventions for the patient that has brachytherapy? Do you have is an actual you're giving the treatment at that point? What is brachytherapy? Different from radiotherapy. Remember that we have two kinds of radiotherapy, the ones that is external, the ones that is internal. We put the tube there and we target the organ, right? We inject that radiotherapy through the catheter. Okay, so what do you care for that patient that has a catheter and you actually giving the therapy? Well, it's not going to be synchronized, it's going to be the catheter. Yeah, okay. What else? That goes very slow, so the patient's going to be very bored. So you have to give them something to do, right?
Also let them know that you're not going to be in there a lot.
Perfect.
For the patient.
Perfect. You have been studying. Very good. Limit the time again, follow all your radiotherapy protocol. And you have to tell the patient that you're going to be coming at least every, 4 to 6 hours, which the patients get very frustrated. Very frustrated. Okay, any other questions than what we saw last week? Okay. Good. Let's continue with lung cancer. Okay, leading cause of deaths in USA, lung cancer. Main cause, smoking, right? Higher in African Americans, higher men than women. When you are a smoker, okay, and remember, you always, and that's part of your protocol in the hospitals, you always need to talk about smoking. How many cigarettes? For how many years? If you're a former smoker, when did you stop smoking? Because that's part of your history and that's part of the risk. Okay, even though you stop smoking, I have seen patients who stop smoking for 20 years, suddenly they come with a tumor in the lungs. And it's depressing. Once you stop smoking, if you decide to stop smoking, you need to have 10 years in order to clean your lungs. So always ask as part of your risk prevention. Risk factor, again, smoking 90%. The tobacco has 60 different carcinomas. And what it does, it damages your epithelial tissue. The one that protects the lungs on the outside is completely gone, and it doesn't regenerate, unfortunately. It can have an additional tissue. It's not going to be the same. It's going to be harder, thicker after 10 or 15 years after you stop smoking. But again, it's not going to be the same. So you see, even if you don't smoke, the secondhand smoking is one of the causes of lung cancer. People who are in highest risk are the ones who live in hotels or use hotels, and there are no smoking facilities. People who live in apartments, especially the ones who have kids, okay, they've had a very high risk to get cancer. When the community agree to, allow the residents to smoke in the apartments. Any homeless population, they're at high risk for lung cancer. I think it's cheaper to buy, I don't know if it's cheaper or not to buy cigarettes than food, but that's what they do, right? It helps with anxiety. And especially if you use alcohol is another risk. Not especially for lung cancer, but for colon cancer. That's a high risk. So if you do both, you have 2 risks there for cancer. People who work with asbestos, and those fabrics where they have to use some minerals, coal, dust, uranium. People who work in mines, okay, extracting some rocks and minerals from those locations. The insurance company, I can tell you, they really fight against that. That's why we see the commercials in TV for the lawyers, trying to say, if you have, lung cancer due to asbestos, come and call me, because that's a huge business. They really fight against the insurance company because they don't want to pay for that. So they're very well prepared, and they get a lot of money if you get that type of cancer. So let's talk about a little bit of pathophysiology. Again, it's studying your epithelial cells. Usually lung cancer is very silent, very silent. It takes 8 to 10 years to start to know the signs or symptoms. And usually at 10 years, you barely have a very small tumor, like 1 centimeter tumor, and keep growing through the years. So it's very slow growth. It's very silent. Patients usually come for fatigue or difficult walking, or very short breath, or more continuous coughing, things like that. Usually lung cancer is more seen in the upper lobes, where you are more exposed to the carcinogens. And in the lower lobes, it's just like a 20% of cancers seen. So metastasis. When the metastasis is very fast, breast cancer patients have a lot of die from lung cancer most of the time because the location is very close, it's behind. It goes through the lymph nodes. Liver is another target organ that you see a lot of metastases. Your liver enzymes are going to start to be high, and that's when you are an oncology patient and liver the enzymes comes high. That's almost 90% sure that you have liver cancer too. And when you have the liver cancer, there's nothing that they can do for you. It's just the last stage, right? It can go to the bones, it can go to the adrenal glands, kidneys, and so on. So, as I say, the first symptoms I ignore. It's just the mild cough, especially the smokers. They say, that's okay, I'm fine. And you can see them struggling, coughing and coughing and coughing, but it's okay. They are good. If you argument with that patient, they are not going to be very happy with you, saying, I told you I'm fine, because they don't want to be lectured about smoking, or they don't want to be lectured that they're getting sick. Okay, and smoking is the first priority for them. Again, most symptoms appear late, when it's very late, and see the chances of the spread at that point are very high. The symptoms start to advance when the cough is really difficult to manage, especially at home, and it comes with blood. That's when patients start to be concerned. When you see the blood in the sputum, that's a huge sign of metastasis, or there is a malignancy there. Okay. These patients usually come to the ER with chest pain, and they think that they're having a heart attack most of the time, but they are not. The bronchioles and lungs are very constricted and very with a lot of scar tissue, because remember, when you smoke, you create some scar tissue, and that scar tissue doesn't expand, so you really come with very severe chest pain. They lose weight, okay, because the short breath is when you see the COPD patients, they lose a lot of weight, and the reason for that is because they get very tired eating, so they cannot complete the meal. That's why one of the best interventions for this patient with lung cancer or COPD is finger foods, small foods, easy, like the Ensure that we talk about it, something easy to swallow once, because just 2 or 3 spoons, they get very, very tired, and they don't want to continue eating. So losing weight, 5-10% is a concern. How they diagnose lung cancer? We had, of course, the chest X-rays, and how acute is that one? It's just 5%. Because sometimes the tumor are very small and they are difficult to visualize through the chest X-rays. So the most acute, to see how big is the tumor and the initiation of the diagnosis, the CT, okay, they can evaluate how is the mass grow, the extension, they can see the lymph nodes there too. MRI is amazing because they can see from where it goes, the cancer, what is the direction of the cancer cells. The PET, that tomography, is more seen in patients who have, who the doctor has question about bone cancer too. So that they advance the test at that point. They have to do the sputum cytology, but biopsy is the more accurate diagnosis there. It's very hard in the histology of the biopsy to differentiate the cells because the epithelial cells, the epithelial layer that protect the lungs probably is gone. So it's very hard to diagnose even with the biopsy. They can do some thoracentesis. In order to have the sputum, sometimes the patients are so dry and so having a lot of blood from the cough, so they have to do aspiration sputum, and that's done by the pulmonology doctor do it in the tank. Again, like the other cancers, the staging is the same. That doesn't change. We see the tumor, the nodes, the metastasis, the TNM process. And stage 1 is a very small tumor, okay? That's the one that's very hard to visualize. But the patient continues with the cough, with the, very short of breath, so they go another test. They can always can see it, of course, with the tomography, but that's the hardest one to diagnose, stage 1. Stage 2, the size increases, more visualized, and you can see it in the MRI with the lymph nodes. There's 1 or 2 that's going to start to be involved. Stage 3, that means that it's spread, and it can go to the liver, it can go to the bowels, it can go to the chest, it can go to the mediastinum, the chest part of the bone, and 4 is metastasis, that's the last stage. So how we prevent? You as a registered nurse, your main job is prevention, always in cancer. You screen these patients. The highest risk patients are the ones who, first African Americans, of course, the ones that are between age of 55 to 74, smokers or former smokers, that you need to screen those patients, even though they are young age. If you are 28, 30 years old, you need to be screened for lung cancer. These patients who high risk, sometimes it's recommended to, by the primary doctor, have chest x-rays at least once a year, and the insurance covered for that. Again, nurses are the most closest people to educate the community about lung cancer. If you had to choose a place where you want to participate in these programs, for example, high school programs for adolescents, teens, smoking prevention, those are very good places if you want to volunteer. They have some programs here in the college to, talk about smoking. I'm grateful that the hospitals put in place a policy for no smoking for all the employees and all the patients. So hospitals offer those programs for free for the employees if you want to quit smoking. And actually, if your application, maybe nobody has told you this, when you start to apply for your jobs next semester, they are going to ask you if you're a smoker or not. Okay, if you say yes, there's a no immediately. You're not going to get an interview. Yeah. So if you are employed in the hospital and you're still smoking, they put you in the program, human resource follow you, they give you all the resources, but at the end of the day, if you go to the floor smelling with the smoking and you scrubs, they let you go. Okay? Because we try to work very hard with patients to not smoke in the hospital, even though the patients, they go against the policy or against the rules and they go outside and smoke. But your job is to tell them not to go to smoke. And how do you protect your license in that case? What about the patient who go out to smoke and failed? We had a patient in McKinney that failed and we had to do a hip replacement. He was smoking in the front, in the main lobby, and he failed there. So we had to pay for it. The hospital had to pay for it. Yeah. So how you protect your license? Of course, you tell the patient it's against the policy to go down to smoke. Some hospitals have some waiver form that they can sign. However, not the hospital doesn't have it like Medical City because everything is patient expectations and patient happiness. So we don't have that form. So what I do when a patient wants to go down to smoke is tell him no, they cannot go to smoke. It's still he goes in his own risk, and I document immediately. Patient leave at this time, patient went downstairs, policy explained to the patient refused it, and again I document when the patient back. And the other thing that I do is I call security, tell the security guard that my angels in the hospital, I had a patient smoking downstairs, so keep an eye. They cannot do anything, unfortunately. What is your question?
I was going to say they have to, I've seen it often, they have to sign off the unit too because they're under our care. And if they leave and don't sign off the unit, that's kind of on us too. I mean, you can document, but they also make them sign off the unit and sign back on when they come back.
Yeah. In the case of hip replacement, what we had to pay is because the nurse didn't document that the patient leaves the unit and back or never back. Of course, it's no. I can consider that's not her fault either because you have 4 patients. They're very sick. This patient was in PCU. So in PCU, you have very sick patients. You had drips, everything. But she fell in calling the security and she fell not documented. So we had to pay for that hip replacement. Okay? Okay. What do we do for these patients? Most of the patients can go for the surgery, depends on the base of where the tumor is located. To be candidate for surgery, you have to be between stage 1 and 3. 3 is the most risky when you go to surgery. Why? Remember, we talked last week, tumors create their own veins and arteries, right? They have their own circulatory system there, so when they remove, they can bleed very badly, okay? Last week we talked about what is the name for removing that tumor. Remember? Remember this word? When you remove a tumor, the cavity, because the patient's going to ask you for that. And start with D. Exactly, the bulking. There you go.
I'm sorry, what is it?
The bulking. That's when they go and try to remove as much as possible of the tumor. However, they cannot remove the entire sometimes because the circulatory system of the itself. Okay? So, but they remove as much as possible. After surgery, they go for radiation. And they can have some chemotherapy. So remember, especially radiation in lung cancer is very effective. And they can remove part of the lung. So they have to go discharge for rehab, pulmonary rehab, where they start to use, only what is left in the lung. People can live with one lung. Okay, so they can remove the entire one of the lungs. It's amazing how the human body recovers, right? And work. You can live with one kidney, one lung. So before considering surgery, this patient needs to be evaluated by pulmonologists for see how much capacity on the lungs they have available. How much is involved in the cancer, okay? There is certain percentage that you don't need to know because as a doctor diagnosis, if they say like a 20% of lung capacity, possible surgery is not going to happen, okay? Because there's a lot of lung tissue involved. If they say, well, the lung capacity is 50%, it's a good chance that they can remove part of the tumor and eliminate the other part or whatever is left with the radiation. ADGs in these patients before surgeries are essential. Usually the doctor sends 3 days for ADGs and see how is the pH and how is the oxygen with activity, after activity. So it's a very long study before the surgery. Any questions about lung cancer? For colon cancer, okay? I want to say something about colon cancer and the way you prepare for the test. We are going to talk a little bit about colostomies, ileostomies, and this type of cancer. However, in this test, you're not going to have questions about how to take care of those, okay? And that's going to be happening in immunity, because you're going to see some disorders in immunity that need colostomies or ileostomies, okay? So for cancer, colostomies, ileostomies is the same care, no matter what. Fortunately, always see in more African Americans. Also in patients who enjoy barbecues, red meats, yes, and Texas, yes. More common in men than women. Again, we are the women. Women, we are the ones. But yeah, unfortunately, African American population, they suffer a lot from colon cancer. It increased with the age, so the older, the most risk. 90% of the cases are detected in people who are more than 50 years old. So again, the risk factors that we have: red meats, processed meats, all those delicious sauces, all those things that you eat in barbecue. Unfortunately, that is a risk. Obesity, alcohol, that's one of the major risks, okay? Combined with long-term smoking. Also, patients who have irritable bowel disease. It can be inherited, that's just 5 to 10% of the cases. And people who have history for family members, second or third generation with polypops disease. The polypops, remember, they are like a little blisters, so we can call it little balls in the bowels, in the large intestine, that they can erupt and create a scar tissue, and they can get some cancer cells there. So adenocarcinoma is the most common cancer in colon cancer. It starts in the polyps. Okay, you can see one here, how it looks like in the colonoscopy. Usually it's 85% of the cases are raised from these polyps, okay? So we have two kinds of the polyps. That we have the hyperplastic polyps, and they can grow more than 5 millimeters. They can cause some symptoms like abdominal pains, things like that. But most of the cases, these ones are the ones who are benign, so they can be removed. I had a close friend that he had been had to remove twice, and thanks God they are benign. There's another one, the polyps that we have, the adenomatous polyps. And these are the ones that produce cancer. They grow and they can cut the bowel walls and cross those bowel walls. When the tumor grows, and they can spread very fast. The inherited cancer, the one we talk about, 5-10%, is also called the Lynch syndrome. Remember, it has there are 4 mutations in these genes. I don't expect that you know those genes. That's just for your information, but it accounts in 5% of the cancer. this type of genetic cancer can spread in the small intestine most of the time. It can go to the liver or any part of the urinary system. So signs and symptoms of the colon cancer. Again, we ignore those symptoms like lung cancer is very silent. We can have some constipation, a small bleeding, when you have bowel movement, when you have some mild abdominal pain, some bowel change, some obstructions. But we most of the time believe that's because what we eat or food poisoning, things like that. So it's diagnosed very late. At early stage, we can see some patients have some abdominal pain, so they stop eating, so they lose weight, some tenderness in the abdominal area. And in more advanced, you can see some feel like something, a ball in your stomach, and it's you can see large liver and some ascites. When the tumors in the right side on your bowels, it can cause severe diarrhea, and when it's in the left side, it can cause obstruction. Okay, and the left side is because we have the main colon right there, and it's some people have to be admitted for paralytic ileus due to the obstruction. In this picture, you can see the signs and symptoms in different locations on the bowels. Like in the transverse colon, they can have some pain, again obstructions, they can lose blood, so they start to get anemic. So diagnosis, sigmoidoscopy can be done every 5 years. Colonoscopy is the most accurate diagnosis test. Actually, the insurance cover for any kind of, if they see something, the abdominal X-rays on the MRI, that's the first test that they do. The insurance immediately approves the colonoscopy. Colonoscopy. What is going to base on your test, most part, and in this test is how you're going to take care of that, how you're going to prepare the patient, okay, how you're going to do after the colonoscopy, what the patient is going to feel. Patients are very reluctant to go to colonoscopy because they think they're going to be awake. So by my own experience, I can tell you that's the best sleep I ever had with Propofol, okay? You can be having the best sleep ever. And I was very upset because my husband waked me up. Yes, I said, why you wake me up? It was like I don't know. Now understand why Michael Jackson died. Right? Yeah. It's the best, I don't know what it is, but I was in heaven completely. So you have to tell the patients, encourage them to have the colonoscopy when they need it, not for the Propofol, of course. We don't want to encourage that kind of behaviors, right, or feelings of sensations, but we want to encourage them to have the test and tell them they're going to be sleeping, they're not going to feel anything. Some patients are so concerned because, they see themselves something's coming, inside, so it's very scary. But some patients, especially in the hospitals, we can prepare them with some Xanax or Ativan before going to the procedure. Okay. They also have the double contrast variant anemia. Be careful with this anemia in patients who are diabetic, okay? Because if they have taking metformin, they're going to have this kind of anemia. They can kill your kidneys. Of course, the fecal occult blood test and the fecal chemical tests are the new ones that we can do every year. Okay, they send it to your house. We're going to talk about those in a few minutes. Again, colonoscopy is the gold standard for the, diagnosis. At the same time they do the test, they remove some tissue for the biopsy. They can remove the follicles in the same time, or any abnormality that is possible. It's a very small tumor with very, very minimal veins or arteries or circulatory system. They can remove it right away right there. So that's why colonoscopy is an advantage and it's a very good exam. People who are in high risk, African Americans, okay, people who smoke alcohol, things like that, they can have colonoscopy every 10 years. That's what the insurance approves, and after, if they are older than 50, okay. Here, the African Americans, I just saw that they can start having that at 45 years old. The staging is the same that all the cancers, okay. When we talk about the diagnosis here, they can get a diagnosis in the initial part, 96% of the patients with colonoscopy, of course, and in a stage 4, which is more advanced, people delay that and delay the time, and some people doesn't have insurance and some economical restrictions, so they only diagnose 8% of the patients, and it's very late stage. So in this one, they show you the stages right here. You see the stage 1, very, very teeny, the stage 0, 1, stage 2, 3, and 4, and your lymphatic system is right there, very close in the bowels. So they can go to surgery for bowel resection to remove the tumor. They can go for surgery for explore how big the tumor is and remove whatever is there. They're going to remove the lymph nodes. And the goal is trying to preserve as much as possible to give you a normal bowel function, right? One of the scariest part about colon cancer or any kind of GI problems is to have the colostomy back, right? And they care of that. There are patients that are very scared about that. That's why sometimes they don't go to the doctor, okay? So how we prepare for these patients, okay? Go lightly. If you are in your home and you prepare yourself, they have some kind of go lightly. It's different from the hospital, but do the same function. However, for you and for the NCLEX test and for the practice, you because you're not going to work, or you work in the doctor's office, it's going to be different. But hopefully you all work in the hospital, you're going to stay Golightly. 2,000 milliliters of Golightly, okay? If you are a PCT, like Ali, or some of my peers there, you're going to have a hard time, especially night shift, okay? Especially if the patient is immobile. I don't know how we do this Golightly in patients who are in bed. It's very hard because you clean and clean and you can see the excoriation skin, severe, constantly diarrhea, and that's what we want, okay? The patient is not very well prepared in the morning. The GI doctor is not going to be very happy with you, and he's going to go to your manager and say, the night shift nurse didn't prepare my patient. I had everything ready in the GI lab, and what happened? That's going to happen. And you're going to be called to the manager office. Okay? Unfortunately, that's how it works. So Golightly is a big tank, 2,000 milliliters. You give it as much as possible to this patient, and we're gonna see a lot of diarrhea. You know that the patient is ready to go to the colonoscopy because it's very clear, watery diarrhea, very clear. So that's when you say the patient is ready to go. These patients are going to be exhausted, tired. They are not able to sleep all night. So that's why if you are a very good registered nurse, if you get it at 7 in the morning, you'll be calling the GI lab saying, is everything ready for my patient, right? They're exhausted, they're having sleep, they're hungry, dehydrated. So you really want to check your time with the GI lab. Some antibiotics can be given to prevent, the bacteria to spread or infect more. They can receive some Flagyl before, 1 dose of Flagyl in the GI lab. Again, for exacerbate the good and the bad bacteria. So the surgical decision for these patients, again, remember that word the bulky, okay? Try to remove to reduction of the tumor. And in the stage 1, they remove the tumor if it's less than 5 centimeters. And in stage 2, they do a bowel resection, and they try to join the 2 parts of the bowel. However, one of the major risks in stage 2 and 3 is that when they have a linking, okay, anastomosis in those joints, and they are not, they're not healing and closing properly, these patients are going to have stool around the bowel cavity. When the patient has that, the prognosis is very poor. They die in hours. Okay. If the patients have bowel obstruction, I have seen with severe bowel obstruction after surgery, and nothing is going down. Nothing. Okay. This patient has projected vomiting after surgery, and the projected vomiting is no nice green, yellow vomiting, because that's the nicest one. Is stool vomiting. So you can see the stool flying through you. Okay? That vomit is very high risk for aspiration. When stool goes to the lungs, the patient can die in less than 2-3 minutes. Okay? That's how stool is poisoned. When you have that projected vomiting, you may be calling the rapid response team when you see stool flying on the walls. Okay? And it's very scary for the nurses and for everybody. Stage 3 is treated with a total surgery and chemotherapy. Stage 4 more is for the patients who are, for comfort, palliative care. They can remove the rectum, so they're going to have like a little porch that's made by the bowel. So your care after that is try to see if they can start with a move those bowels. This patient is going to have probably colostomy or ileostomy to rest the bowel rest until it heals. That's pretty much what we do for the surgeries. Again, for reduce the risk for the bacteria, we give the Flagyl. Okay, chemotherapy. These are the ones, the medications that usually did for chemotherapy is the same for all the cancer. Again, we target, see if it's genetic or no, what kind of cancer they have, the stage and everything. You always need to be looking for those signs and symptoms of sepsis, especially in these patients when they are high risk for sepsis because it's stool. So temperature has to be reported immediately to the surgeon, and you're going to have those protocols in place. Palliative therapy is just for reduce the tumor and help with the pain. just a little bit more clear in what you do with your golightly and your nurse management. You have to drink some water before, 2 liters or 2 liters in the morning of the procedure to start, feel more the bowel. Depends on the patient. This magnesium citrate is sometimes given to patients that are at home preparing for the next day procedure. And again, there has to be clear stools or clear fluid coming out. So health promotion, that's your job as a registered nurse. You can again participate on programs in nursing homes, things like that, to be screening. You got encourage everybody over 50, African Americans over 45 years old, and just to decrease the mortality rates on these patients. The follow-up recommendations. I don't expect that you know all these appointments every 6 months or everything, but what you need to do focuses in when they can need is when they can be a screening, especially if you are an African American, and after surgery, after the cancer has resolved, chemotherapy is done, and everything. These are the appointments that they need to follow strictly after the treatment. Okay, if the patient survives and everything, this is what they need to do. Doctor visits every 3 to 6 months. The first year, the CAA test is every 3 months, and colonoscopy every year. Okay. Again, these appointments are for the patients who are survivors of cancer after the procedure. This is just part of the evaluation to follow the nutritional and all follow the outcomes for the patient. I'm going to go deep in that. So let's go ahead and start with the palliative care and comforting oncology patients. Okay. Here is a question about that. Read this question and see what do you think. See? Okay, very good. This diagram explains you a little bit better what is palliative care, and you see it continues here, and it can go to hospice or continue with the treatments. In hospice, it's very, very difficult to see antibiotics given. Very difficult. Sometimes the patients in hospice they get pneumonia, and the family really want to still treat for the pneumonia. They can do some of those kind of sections and give some Levaquin. However, that's not the goal, right? Some hospice patients, they got the pneumonia because the family really encouraged to eat and feed them, and they aspirate even though they can't swallow. You don't want your mama to die hungry. And of your cultural beliefs, that's something that's a big issue, and it's a fight in the hospital between the nurses and the family members constantly, because we want to protect our patients for suffering from miserable aspiration pneumonia. But the family doesn't see in that way. It doesn't see in that way. Even though they are sleeping, they awake the patient to feed it. Okay? And that's part of the culture. We respect that. We just tell them, your mom is aspirating everything is going to the lungs, but it's your mom. You have to respect that. Okay? So, for hospice and palliative care, everybody's involved, social workers, all the registered nurses, everybody, the chaplain needs to be involved. The chaplain, I think are very beneficial because they meet all those family, they can manage the family very well during the process. They are amazing. The chaplains who work in ER, for example, and have trauma patients, they are the ones they are the first face that the families see in the ERs. They do amazing job preparing the family for the worst, okay? Chaplains can encourage or can overcome some decisions. For example, we have abandoned patients in the hospital. Family members doesn't show up, nobody's responsible, we call the nursing home, homeless, whatever, and there's nobody around. And the Air Force and the doctor has to do certain kind of procedure that is invasive. Chaplains are allowed to sign and approve the procedure as an advocate for the patient. Okay, they are the only ones with the physician. So in ER, the chaplains assist in case of urgency, things like that, to sign those consents. They do an amazing job. Be clear about communicating with the symptoms, especially if you're trying to prepare the family, okay? You really want to tell the family what's going on and what they are going to see. They need to understand the expectations. They really do need to understand the expectations. We have an alcoholic patient. She was 40 years old in hospice, dying for last stage of cirrhosis, 40 years old, and the family was expecting that she was getting better and better, and she got the cirrhosis from severe alcohol for many years. However, the family was drinking in the room, celebrating that she was going to get better, but she never did. So you have really to set up the expectations. It's very difficult when you tell somebody, well, this is how your mom is going to pass, okay? And you have to be realistic, tell them what they're going to see. Your mom is going to be short of breath, she's going to have some episodes of apnea. Sometimes she's going to have some episodes of she's screaming, maybe, awaking. You have to manage that incontinence. You have to tell the family members how they died, and this is the hardest part. When you have a patient die in a very slow process, usually humans, we die from the bottom to the top, okay? So we see the first symptoms where we see the bluish color on the legs, no pulses, peripheral pulses are very gone, because what the body do, or what God decided to do with the body, is that the brain is the last part to die, okay? So you need to prepare the family, because once they see the forward legs and everything, they say, oh my mom, what's going on with my mom? Why the legs look like that? So no pulses, they're going to see some edema, retaining a lot of fluids. So you have to tell them, I have a nurse who thinks that is not working with me anymore. I don't see any working any other place, who told me, we don't need to turn this patient because she's dying, okay? So you're going to tell the family you're going to turn this patient every 2 hours to relieve the pain and, still protect the skin. This is a human being. So you still advocate for patients who are dying. You need to tell them you're going to see some secretions. You're going to see secretions, so you're going to connect the suction. Be sure the family can help you to suction those secretions, okay? Especially patients who die for lung cancer, a lot of secretions, nasty sputum, they have to suction that patient all the time. So try to clean the room, maintain very clean, very nicely, because the process is very hard to see these patients. You can tell the patient, and research studies done that, keep talking to the patient, tell them that it's okay to go. It's okay to go. The kids are going to be okay. The family is going to be okay. Mom, I'm going to finish the school. You can go. I'm going to be okay. Okay? Hearing is the last sense that you lost. You can hear after 5 minutes of being dead. Okay? So tell them it's okay to go when they pass. You can encourage the family to keep talking to them. Help them to go. All right? Okay, holistic nursing, we treat for try to prevent some incontinence. Sometimes we have to put a rectal tube and these patients have severe diarrhea. The catheter, we treat for the constipation, of course, environment, everything that needs to be done in these patients. Other things that you need to explain, especially in kidney failure, hopefully you had a Foley catheter in place, and in kidney failure, tell the family they're going to see less urine coming up, okay, because sometimes the bag is empty after 8 hours, and you need to tell them, it's part of the last stage of the renal disease. So we have strict protocols, most of the hospital for hospice care. The protocols include the medications, okay? Those medications, like we have Ativan for severe anxiety, we have the Zofran or the Phenergan. We prefer the Phenergan in these patients because to treat the nausea and the vomiting. You can start the patient a morphine drip. It's not that you're helping the patient to die, it's that you're helping the patient with the pain, okay? So the morphine drips I think they are a blessing. You can go up and down, depends on your patient reaction and the family agreement. 1-2 milligrams, I have seen morphine drips going on 5-10 milligrams by hour, okay? Do not be afraid. These patients are suffering. They are in the last stage of cancer or any kind of pain. Do not be afraid or increase that morphine drip, okay? That just stages out a brief. I don't want to go deep with us. You already talked with Ms. Got the information from Ms. Gill. The fear, anxiety. This is the symptoms that you're going to manage during the last process, okay? Let's talk a little bit about hydration, okay, and especially in the last stages. Remember, these patients, because kidneys are dying, so retaining fluid, and you see the edema. Family, most of the time, require fluids, okay, because you don't want your mom to be dehydrated. Explain again how she's retaining fluid or how he's retaining fluid, but still the family wants the fluid. What are you going to do about it? Let it go. Patient is going to die anyway. So having edema, you have to take care more of the skin, right? And that's all what you can do. The skin care. The nausea and vomiting, we know that some medications like Regnal also helps. It goes through the IV. We try to give these patients all the medications through IV or sublingual. For the dyspnea, we have the morphine really help with the dyspnea, with the shortness of breath, with the fatigue. Even though it decreases your respiratory rate, yes, it does. That's why you had a drip. You monitor that patient, but really helps to breathe much better, especially in the last stage. Again, some Xanax or Ativan, so you can help them. You still can give some respiratory treatments to help to remove those secretions. Just be sure you have the suction at the bedside all the time. Oxygen for respiratory failure in the last stages. But patients, when they are dying, they have the severe anxiety and everything, they can remove the oxygen, okay? Ask the family what they want. This patient at 40 years old that died, for example, she didn't want to die, and she was in the last stages, okay? And she got the oxygen, 8 milliliters oxygen, 8 to 10. Okay, so we maintain care for almost 1 week with the oxygen. It's a 40 years old patient, right? So we talk to the family and we all decide to remove the oxygen to help her to die peacefully, okay? Because she was struggling with the oxygen. So if you have some concerns or you have some ethical concerns in based on your religion or beliefs, it's going to be very hard for you to treat these patients. So you have to put those all apart. Everything that you believe is at the side. It doesn't matter what you believe. You're going to treat these patients with the dignity and respect that they deserve. This is the final stage of the death. Again, a lot of secretions, loss of consciousness, the gut reflex are completely lost. You can use some anticholinergic medications like the scopolamine patch. It's very helpful in reducing those secretions. The scopolamine patch is given, I forgot the dose, but I believe it's every 3 days that will change the patch. Really helps, okay? And I'll tell you about how strong scopolamine is. In Colombia, where I came from, or I was born, they use scopolamine spray to make the people to lose the memory, to decrease the respiration rates when they want us to, rob you something or attack you in any way. Scopolamine sprays are very common seen on the streets. Okay, some people use it for get high, homeless, things like that. So it's not seen here in the United States. In some Latin American countries, they use that for, if they want to rape a girl, they can give her some scopolamine, and they don't realize what's happening around until 8 hours later they are awake with nausea and vomiting. Okay, so that's how strong scopolamine is. In these patients, the patches are released in the skin, so it's very slow release. It's very effective, and it really helps with the secretions. A lot of delusions, hallucinations. Some of these patients struggles because they lose the kids or some family members or loved ones in life, and they can see them in the final stage. They believe they are in the room with them, okay, and they can start to talk to them. It seems, I don't know, based on religion, and I'm very partial on that point. Some people say in the final hours they see, they start to communicate with family members who have died or they are dead, and they are welcoming them to follow, according with the books and everything, to follow the light. Okay, so they start to talk to them. Okay, I don't know if that's true or not. Again, I have to be very impartial in that sense, but that's what we see in these patients. Again, the hydration, I'm not going to go in. Just the mouth care is very important in hospice. Okay, they can have very bad severe yeast infection. So mouth care is very clean that at least every 2 hours. The same like you do the protocol in ICU is patients and ventilators, you need to do mouth care every 2 to 4 hours. Okay, witness. So let's talk a little bit about the medications, especially pain medications, okay? Pain medication needs to be given around the clock, all right? You don't delay pain or nausea and vomiting medications until the patient calls. First, they're never gonna call. And second, you wanna be sure that you provide the pain or the comfort before it gets worse, okay? Oncology patients, for example, with severe nausea and vomiting, you're gonna tell them, or don't tell them, just take it as you need it. Never. Take it every 4 hours, okay? Especially if they put Phenergan, which is the most prescribed, they need to be aware about the sedation, okay? But you don't delay until they need it. Because patients, especially oncology, they learn to live with pain. They learn to live with pain. So they say, oh, my pain is 10/10, so I'm good, I'm fine. I don't need anything. I just get some Tylenol. Yes. No, you don't want that. You want to then feel comfortable, especially in the last stages. You want to have again the morphine drip every hour even. Don't worry about addictions, things like that, because that's not the case. That's not where we worry. You have to be worried about the constipation, so you have to have something at the side for the constipation. Again, the medical equipment, they need to be transferred to the hospice care facility. Some of the nursing homes, hospital, I think the protocol for hospital is 5 days to stay. If they don't die in 5 days, they need to be transferred because that's what the Medicare covers. The DNR, all these documents needs to be ready before when you prepare this patient for hospice. So what is advanced directive and what is the living will? Does somebody has advanced directive here, so living will, like me? No? Nobody?
Isn't it an advanced directive where somebody can make your decisions medically for you if you're not able to?
Yes, advanced directive is first you decide what you want, okay? Your lawyer or whatever who do the advanced directive, they can decide if something happened to me in this case, I want feeding tubes, I want ventilators, I want surgery, all that stuff. If I'm not able to take those decisions, my daughter, which she needs to sign, and everything by the law, she's gonna be the one who's gonna take decisions for me. That's advanced directive. Living will is just last desires, it's not as powerful, it's more for monetary concerns or monetary issues. You need to be sure to know about organ donors. These patients' family members are going to ask you. Then my mom can be a donor. She wants to donor the heart or things like that. If it's a cancer patient, that's not going to happen. Okay. All donors are only patients or candidates who have been trauma, young patients, with no comorbidities. When you come to the call, the patient died, your protocol is you have to call the forensic doctor, of course, and you have to call the donor organ national line and tell them this patient died from this and this was diagnosed. And once they had the approval, they give you a number and release number that the patient is not candidate for organ donors. Okay, but that's mandatory, it's nationwide. Power attorney, when you have somebody again delegate for you last decisions for everything, not just health but everything. The brain dead versus the circulatory dead is the ones who are going to be organ donors. So the brain dead, there's some protocols that you're going to see that in 4th semester, not in this semester, where they have to be maintained in the ventilator for certain amount of hours and the tests and how many doctors need to sign, the family approval, and the process, how they move the patient from the ICU to the OR when they have the donor ready and how they transfer the organs, okay? I want you to focus on this slide, symptoms of imminent death, okay? These are really the symptoms that the patient is very, very close. It's hard to determine when a patient or the family is asking you, how long more my mom is going to be here? Is my sister able to come? And when you see these symptoms, that's when the really is going to happen, possibly in less than 1 hour. Okay, so you want to prepare the family. That's going to happen soon. The blood pressure start decrease, and if you are very good caregiver with a big heart, okay, you want to talk to the family to stop vital signs, to stop the telemetry. If it really upsets me when a patient in hospice has a telemetry on, it really upsets me because it's more uncomfortable to have that box set in your chest. You remember your peripheral nerves are dying, so it's painful. These patients, when they're taking blood pressures, taking blood pressures and vital signs stay more anxiety for the family, so they can, because they see, the respiratory rate from 12 to 4, so my mom's dying, the blood pressure goes from 110 to 60, 40 systolic, so what time is going to happen, so it's worse. And it's worse for the patient. It's painful to take the blood pressure, even though you are, normal, like we are, and it's painful. Imagine a hospice patient dying when peripheral neuropathy. Very, very painful. So you try to encourage the family to stop those vitals, and you see once they were in the hospital, most of the time, that's part of the protocol. And if the family still is very reluctant to say yes, we can tell the doctor, you need to come and talk to this patient, to the family, okay? They believe sometimes more to the doctor than to the nurse. This is just a chart of everything that we do. I include this one because it has everything in palliative and hospice. So it's just for your information. Okay, cancer pain. Very intense, and the last stage is intense. The tumor, we talked about that before. It's very chronic. It's very associated with, with all the symptoms. Some pains are so extremely horrible that even morphine or Dilaudid can help them. They can have 10 milligrams of Dilaudid sometimes. In clinical, this yesterday, we saw a patient, an oncology patient, with 50 milligrams of oral morphine. And my second semester, I was thinking about my second semester. But we saw 50 milligrams of morphine, and my students were asking me, that's an oncology patient. So 50 milligrams, you see the huge dose, because usually we see 1 or 2, right? Oral medications can go high, 10, 50 milligrams of morphine. That's assuming 1/4, and again, you really want to treat that patient with the pain. The goal is to maintain the pain as low as possible, and low can be 4 or 5. That's all. You don't go to 1. So again, don't be afraid of that. Treat that patient. This is what the World Health Association say that we need to support that, manage that pain with the opioids. I'm not going to go on the stages of pain, especially because you already saw that. You need to know your skill, how you treat a patient, a normal patient in the hospital with no hospice patient. For this pain between 0 and 4, or what are you going to give to that patient, right? Pain between 5 and 7, you start with the narcotics right there, like Norco, and 8 and 10, you really want to go with morphine or Dilaudid, high level of pain, all right? Fentanyl patch, I'm going to talk about that in transdermal opioids. Okay, one of the favorite drugs on the streets now. A patch can last long because they cut the little pieces in the streets. For patients, we have 50 milligrams or 100 milligrams of fentanyl. Fentanyl is 100 times higher than morphine dose. For 1 milligram of fentanyl, you have 100 milligrams of morphine. That's how it is. It's released slowly in the skin, very, very slow. You change the patch every week, okay? That's why people get so high when they smoke those patches. I didn't say this before. If you change the patch, be sure to witness that somebody's with you, that you're taking the patch with you home, because that happens, okay? So just be careful with that medications. And hospice patients, go ahead and put the patch, 100 milligrams. Because that's going to help with the pain. We just talked about the cancer pain, what we can do with those patients. Corticosteroids also help with the pain. Yesterday, actually, we saw a patient with chronic the patient cancer has taken prednisone 5 milligrams daily and has been taken for the last 2 years. So this patient has, the wrong face and all that stuff. But corticosteroids really help reduce the swelling and everything, and really helps with the pain. So it's like an adjunct therapy. This is your ladder. Remember, you saw that in first, second, and third semester. So I'm not going to go over that. And just treat the side effects of opioids. And this is some common medications given in hospice care: the morphine, fentanyl, Toradol. Toradol is the injection or IV. If there's a patient who has a good kidneys, you only can give Toradol 3 times or maximum 5 times because it damages your kidneys. So as a hospice patient, it's okay because kidneys is working. But as a patient has a good kidneys, as an oncology patient, you have to be careful with that. It's just something that's adjuvant therapy. Okay, very common seen in orthopedic surgeries to manage the pain. Ibuprofen, also looking for the GI bleeding in these patients. Aspirin, the codeine, some antidepressant medications as an adjuvant medications too. It helps to manage the pain, and something for nausea and vomiting. Okay. Okay, let's start with the TB cause for main bacterial, mycobacterium, tuberculosis. Involve all the lungs, okay? It can affect all the organs. We're going to see that in a little bit. However, the target organ is the lungs. TB is the leading cause, unfortunately, after pneumonia in HIV patients, okay? For somehow they are very prone for TB. When you work in the hospital with HIV patients, be very sure to screen those patients for TB. This is part of your immunity concept, how it's interrelated with other concepts. Okay, risk factors for TB. Age, young people is more prone to contract TB. However, the ones that have worse effects of TB after being exposed are the elderly, okay? Or patients who have a very low immune system, like HIV patients, babies, anything that's immune system is compromised. Most seen in poor communities. That's why, for example, in Philippines they use they give the vaccine to everybody because it's a high risk for contracting TB. Vietnam is one of the countries that use also the TB vaccine. And here in the United States is no use at all. It's by choice. You can request that in the health department. However, it's not very frequently requested because the contagious is very low. Okay, there is some years that maybe has been a little bit high or more surveillance, but the health departments keep an eye on that very closely, and it's very, very low to see here. Patients who come to the ER, and I'm going to refer this like a good example of the Ebola. That was part of my my research study in Medical City Dallas for my master's. And Ebola, how people criticize the system, how this happened, how the contagious happened. And the triage nurse, what I found that is that she was following the protocols. However, it was no very strict protocols in how to screen those immune disease conditions, right? In the case of Ebola, she just say, okay, or he or she, fever, nausea, vomiting, abdominal pain, put in the bag and send it home. Okay, so the patient was not very honest in that case. So when I refer this case about Ebola and TB, patients sometimes are ashamed to say what's happening or the history or history in the family. So you need to be very, very sure that you screen that patient very well, especially in triage in the ERs, okay? There is special protocols when you have a possible TB patient, immediately place it in isolation room. Even as a minimal question, they're going to be in isolation, right? So the global view for TB, and this is from the CDC 2018, it's just for your information. Healthy people can be infected, just 10% of the people have that risk. High risk people, again, who has issues with nutrition, issues with diabetes, anything that compromises the immune system. People who use tobacco, okay? Tobacco reduces your defenses. Tobacco really damages a lot of your organs, your blood starts very, very thick, you are very prone to clots, infections, and so on. This is what I care that you learn, because this is what is actually you're going to see in the hospitals in the NCLEX test. The latent is the one that reminds, we can say, sleeping in the body. Patients have the antibodies for that, and they are the ones who the disease is no with signs or symptoms. As they know coughing or sneezing, things like that, they are not able to infect anybody else. In these patients, for example, when it's latent, for example, the patients that have the vaccine that comes from Philippines or any other countries, they can have positive skin test, okay? However, when they go to the X-rays, they are negative. If you are a healthcare worker, the protocol for your hospitals or when you get a new job, you're going to be screened for TB. So if you come positive and you say I had the vaccine, no matter what, you're going to go to the X-rays, okay, to show that you are negative. And they're going to be negative in the sputum too, okay? It's just something, the virus is sleeping in your body. It's like any other vaccine. When the TB is active, the sputum is positive. They're going to go with the bacteria. The positive skin reaction, they're going to have positive X-rays. You can see very clear the cavitation. I'm going to show you that in a few. And these patients look very sick, wasted, sweating a lot. They're not able to sleep during the night, losing a lot of weight. And if you have seen Meditech or those systems that Epic that they use in the hospitals, the main screen when you have an admission in ER is that, the TB screening, and that comes with these, with questions about the screening. So how tuberculosis spreads? It's very contagious, very contagious. These patients need to be in droplet precautions. Somebody knows what is droplet precautions? Okay, I want to hear. Mask, gown, gloves. And what kind of room they're going to have? Negative room, right? So again, what happened with the Ebola? The nurses follow the protocol. However, they didn't know how aggressive it was. The same like TB. TB can be aggressive. Sometimes in my practice, I use double mask. Okay, there are nurses that are not able to go inside the room, like pregnant nurses. Unfortunately, that's the only condition that, or you need to have some kind of immune system disorder if you're a healthcare worker, and only that they excuse you for not going inside the room. Everybody else needs to go use the precautions and need to go inside and, attend the patient.
Do they give not ask a special suit now for Ebola, or no?
Now they after all that we did, the studies and all that stuff, we have different suits. We have something that is completely covered and it's a special material that doesn't allow, like the same thicker material that they use with the N95 mask that the virus doesn't cross. So the materials cover you completely, okay? It's gonna be a complete mask, shoes, everything. And they had this, when they go to the ER, there's a special way to go directly to the specific room in every hospital. And now in the United States, they have those protocols where the patient can walk and they away from the other ones and put them directly in that room, okay? Emory Hospital, that was the one who really had all those preventions before. They were very well prepared. That's why they were very successful treating those patients with Ebola, especially the nurses who recovered. So again, these patients spread, with the sneezing and any cough, any droplet can cause any contagion. So this is your airborne contact precautions that we want to have. This is from the CDC, and I believe this is in Europe. But basically, you need to mask N95 every year. You're going to be fitting the mask because as you gain weight, like me, and you get older, like me, your face change, get more brown, more fatty, right? I'm not the skinny one anymore. But that's what happens when you age. Your face change, your nose grows. Horrible. Horrible. Have you seen the elderlies? Some elderlies that has a big nose, and you see the pictures when they were young and they were very nice, straight nose, and now they have a huge thing here. Yeah, so that's gonna happen to everybody, okay? Just not me. So just wait. So yeah, you need to fit every time for a small, medium, and large size for the mask. So assessment of the TB. Let's go this. We had the pulmonary TB or extrapulmonary TB. That's the one that goes to the other organs. Basically, we usually see the pulmonary TB. This is some kinds, so the different kinds of TB. The military TB is called like that because it's more seen in our troops. However, today they had a lot of preventions and things like that is very, very seen. The assessment for TB, of course, the history, where you came from. That's a big question on your screen. Where you came from? When was the last time did you travel out of the United States? For how long you were out of the United States? What country you were? The history, any sign of symptoms, of course, we talk about that. Exposure, if you were in an airplane, something like that, if somebody was coughing. So I feel sorry for the people who were starting with the Ebola patient, how scary they were when they realized, that the guy was sitting next to me, or, it's very scary. The previous infection, they had a vaccine. They had some conditions that come from TB, like HIV. People who smoke, COPD is a huge one too, because they usually come to the hospital with chronic pneumonia. So in adults, TB, we see the cough, the body, bloody cough, chest pain, losing weight, the night sweats, fever, and severe fatigue. The extrapulmonary TB again is going to the organs, and this depends on which organ is affected. However, when affect the kidneys especially, they start to see some blood coming in the urine. It is affect the neuropar. These patients are going to be very, very confused, and they are going to be with severe headache. These patients with TB on the brain needs to be in dark room, and additional to the isolation. So can you imagine this patient isolated, dark, the risk for suicide or do something crazy is very high, right? That's part of the human being reaction. If you keep the patient 3, 4 days, 5 days, 6 days, 10 days, worse and worse and worse, okay? So you really need to be checking on these patients even though it's an isolation. Meninges are the main affected on the brain. It's good in one way, the meninges protect the brain in that way because reduce the pain. Because it goes deeper, in the main part, you're going to be very confused. You're going to have some kind of dementia. So we just deal with the pain at that point. The spinal, the patients complain of back pain, and the other organs, liver can go to the liver too, so abdominal pain too. So diagnostic studies, we do, of course, the TB test is called Mantoux test. Be sure to know that because that's part of your NCLEX test. It's going to be in your NCLEX books. If you start to study with questions, I hope, right? Everybody? I hope so. This is the kind of words that they're going to use in your NCLEX test, okay? That's a standard method for everybody. If you inject 0.1 milliliters, that's going to be in your NCLEX test for sure. Intradermal, okay? You should have, when you inject, you should have like a little bubble. I'm going to show you in a few. And that's the ideal, okay? So if we see some induration or no redness in the injection site, that means the patient has been exposed to TB in some way. And here's how you measure your results after 48 to 72 hours. If the patient is 5 to 9 milliliters, he is possibly exposed. This one should be in isolation. 10 to 14 positive for the person as level 2. And more than 15, that person really something is really going on. So those kind of measures maybe not for this test, but for the NCLEX test, you need to know those. So there is this is on the stage that we use for classification of the TB. 0 is very flat, it's just a mild redness, it's no exposure. 1, it has some kind of exposure, and so on. You continue with the 3, 4, 5. And diagnostic studies. So there is blood tests, of course, they're going to drop for see what is the immunity reaction, especially the T lymphocytes are involved in the attacking those that bacteria. Remember, and especially for 4th semester and in my clinical, I really encourage students to know what are the basal links, all those white blood cells, different types, work on the body because each group defends the body in a different way, right? One group defends the body against bacteria, other group against fungus or parasites, and other one for virus. So know those ones, and that way you know that the doctor is giving the right antibiotic for the right condition, right? And you monitor those group of soldiers to fight against that. Diagnostic, of course, the chest X-rays, and you can see the cavitary infiltrates. It looks like a holes in your lungs with some fluid there, and the sputum. So this is the lung, how it looks with the cavitary, the holes that I was talking, and that's how the bacteria places itself in the lungs. If it's in the lower lobes, it's very hard to fight that bacteria, very hard. And we're going to talk about the treatments in a little bit. This is some key points that you really need to know. 3 consecutive sputums, and this is from the book and this is from the hospital protocol too, needs to be negative, okay? Each one is collected in intervals. The symptoms may improve during the time the patient is in isolation, and still in some kind of question, the patient can have 2 weeks of prophylactic treatment before being discharged. So clinical management for the TB, we of course screen everybody and the triage and the health departments, the protection precautions, and the main goal, you as a registered nurse at the hospital, if you were in home health or in health department, is to follow these patients for compliance. This is the biggest issue in TB. Medications. So you need to know these medications, right? Especially for all these 3 target your organ, okay, is the liver, which is the major toxicity of all these 3 medications. So you can see if these toxic medications are, you can see signs of symptoms of liver failure, like high liver enzymes, but in patients who, has not been taking blood drops, you can see the yellowish color, jaundice in the eyes and everything. That's a huge mean that is toxicity. It works the same like Lipitor. Remember Lipitor, we talk about how affect the muscle because the myoglobulins from the muscles. So those comes from the liver. That's why in Lipitor, like these medications, we monitor the liver very close at least every 3 months. Okay. So, for example, let's talk about rifampin or Rifadin. That medication especially works in the inhibiting the replication of the bacteria, so it stops how the bacteria multiply. You have to advise the patients, especially that are in long-term therapy for alcohol. It's very hard if they drink alcohol once in a while, socially, or daily. So alcohol is going to make your liver and put in very bad stage. So the initial phase, it consists 2 and 4 medications combined. I don't expect that you remember the combinations because as a doctor ordered, what I expect that you know is how to follow these patients after. Okay, it's prescribed and what is the toxicity. The prescription just give it for 8 weeks sometimes. The continuous phase after they finish after 8 weeks, they have to continue. Sometimes this is what the books say, but sometimes they have to continue for 9 months the therapy. So again, it's very, very hard to follow these patients. The health department has a special parameters. Once you have a TB patient on the floor, you need to report that to the health department. Social workers usually do that, and they immediately start to follow this patient at home. They send a social worker or a home health nurse from the health department to monitor the bottles and see if this patient is taking the medication or what's going on. Sometimes they have to provide the medication for free in order to ensure that they have the therapy, especially for poor communities, okay? So, again, the health department doesn't release the patient until the therapy is complete. This is another option, option 2 for the drug therapy, but it's most basically the same. That's the doctor's decision what kind of therapy, depends on how bad the TB is, okay? This is just key points that you can read those. Again, the first line.
I don't know if it matters, but with I can't say it, the risk factor, however you say it, has a lot of to do with like
Yeah.
The list is so long.
Yes, that's correct. Great food also interact, and those interactions are in the book. Again, every medication that we target the organ, I like to say the word target, is because you had to really be careful, monitor, the failure and what interactions have. But thank you, Elizabeth. I hope. Okay, the first line of drugs again. We have four different kinds of drugs taken in once. It's a lot of pills. So there is some patients who have been exposed and they're very resistant. Those patients need to have a high level of drugs, and I'm not going to talk about those because, again, it's a doctor, it's a different protocol. But basically, sometimes they had to have some injectable medications they had to have for the health department. I think the health department is the only one who had access to those injections. So this is just for your information. Let's talk about the vaccine, okay? Because it's something that you need to know, especially if you're going to work in ER. So it's called the BCG vaccine, okay? It's a live vaccine. I don't know what is in the other countries, the protocols, but this is the kind of vaccine that you don't want to give a patient who has low immune system, right? So it's called the Mycobacterium bovis. And this is given to all the infants in that part of the country. It's not recommended again here in the United States. And it results in the false positive TB skin test. Your main job as a registered nurse is be sure that everybody who needs to be followed to the screen program, especially in groups. If you work or volunteer in homeless, to visit the homeless at night time, things like that, you really want to have some TB tests with you to screen those patients. Be sure that you have your isolation and you follow the protocol for the hospital for the chest x-rays and things like that. These patients sometimes need to have a high therapy of oxygen and respiratory treatments. Those respiratory treatments really help them with the cough and secretion. Sometimes it's so bad that they had to put a chest tube because the bacteria literally can eat part of the lung and deflate the lung. So these patients are in severe respiratory depression, and it's an urgency, and they really need to be with the chest tube. That doesn't mean that the patient needs to be in ICU. That means that the doctor is going to kind of put in the room, in the isolation room, and you as a med-surg nurse or any nurse can monitor chest tubes. Chest tubes, you're going to see those in 4th semester, but you're going to be really getting your expertise and your internship, okay? They're going to show you how to use those. Okay, you can go home.